Okay, we've had a lovely request to do the cardiac one first, which we have just switched them up, which I hope that's okay with everyone. So this is something for this lecture. I really want to focus on those little white fluffies. I've heard that you've got a few of those over here in mitral valve. So myxomatosis mitral valve degeneration, we're going to focus on that left congestive heart failure and the acute presentation with mitral valve disease. I want to go through recognizing acute congestive heart failure, sometimes without many advanced testing. If you don't have, who has access to a cardiologist or referral? Yeah, a few. Okay, you've got some. I didn't realize you had cardiologists. Okay, that's awesome. Differentiating cardiac from respiratory disease, stabilizing with oxygen, sedation, and furosemide, and then confirming your diagnosis, and then moving on to therapy and oral therapy and home care we'll finish up with. So this first video, I've just turned the audio off because these guys were talking in the background of it. What do we think of that breathing? This little dog is really working hard, quite dyspneic, quite orthopnic, just focusing on breathing and tired. You can see in their little eyes they get really tired when they've been struggling to breathe. So little Benji has a history of being 12-year-old, male-neutered. He's always had a heart murmur. The vets have always picked it up at his vaccinations, but it's never caused him a problem, the owner said. In this last month, the owner kind of thought maybe he was breathing a little bit faster, and he'd had a soft cough for this last week and not wanting to go on his walk. He didn't want his breakfast this morning. So what are you going to do next? Again, ABC. So this is when I'm assessing these respiratory patients. I'm trying to get clues from my physical exam to direct me one way or another. With their breathing, are they got a patent airway? Are they moving air? Yes. Sometimes in these end-stage congestive heart patients, they've actually started to cough up that pink froth, and we call it the pink froth of death. Normally that's severe fulminant pulmonary edema. But if you're seeing that, it's kind of a bit of a hallmark for pulmonary edema. I have a really good listen to their chest. Do I have crackles? Sometimes it's when you're listening to these guys and they're breathing like that, you're just hearing such it's so noisy in their chest, but they've normally got a stonking heart murmur. So, but having a really good auscultation, taking your time, have you got an arrhythmia as well? Look at their perfusion parameters. Don't just panic because they look like that. But sometimes they can't handle much of a physical exam. You literally just have to get them into oxygen, otherwise they're going to arrest. So it's a very cursory, quick exam. I'll be looking at, their mentation clues. Are they tired? You can see that little dog's probably been steadily working hard to breathe for days. Looking for other signs when you're assessing cardiac patients. We're not going to get into right-sided failure today, but you look for jugular distension. Have you got abdominal effusion? These are all signs of right congestive heart failure. You're starting to use your primary survey in your physical exam to help you decide a little bit, airway or heart. What are we dealing with? These little dogs that come in and, the coughing dog, and this is something where it's not, coughing doesn't straight away correlate with heart disease. To be honest, the coughing dog is much more likely to be an airway disease. The mitral valve degeneration kind of goes hand in hand with chronic bronchitis and the collapsing trachea, or we call it the dynamic airway syndrome, because it's a degenerative process of the cartilage as well. So the same process that's happening in the valves is happening in your airway, and you're getting collapse of that. So these little guys, they can have one or the other, or they can have both. Heartworm is something I looked up last night. Heartworm is quite prevalent over here, is it, or not? Oh no, okay, no. We do have a fair bit of heartworm in Australia, and it's more in the north of Australia, but we are seeing it more and more. So airway versus cardiac. Already just from the history, what clues are you trying to get? And it depends whether they're in they've got how much pulmonary edema as to how sometimes obvious these are, but you think the little bright, happy, coughing, hacking dog, they're normally got a good, normal attitude. They're often got the normal appetite. They've had a really chronic duration of their cough. Sometimes it's worse when they're excited or pulling on the lead. It's quite harsh. And when you look at their resting respiratory rate, it's less than 30. And they're not dyspneic with it. They seem quite comfortable with it. Whereas the congestive heart failure guys, they're often, once they're in trouble and got pulmonary edema, they can be depressed. They're not wanting to eat. Their cough duration is generally shorter. It's sometimes been those last few days or weeks that we've noticed a softer cough. The coughing is any time. It's not as related to exercise. Sometimes they still, and to be honest, sometimes we see them with both. So it's a bit of a grey, they kind of muddy the waters. Their respiratory rate, once they've got pulmonary edema developing, their respiratory rate is increasing. So that cutoff for normal, kind of 30 breaths per minute. But you get to know your own, I've had cats with congestive heart failure. You get to know your own animal. So they're a certain dog's normal. One dog may have, their normal is 18 breaths per minute, and they're always in those high teens. Whereas another dog may sit around 25. So there's a variation of within each individual dog of what they're normal, but a good cutoff is 30. Versus moving into your physical exam, you go, right, what could I pick up just off my physical exam? Sometimes when they can have an underlying heart murmur, they're not clinical, they're not got pulmonary edema, but they've got airway disease. If you've got congestive heart failure, in left congestive heart failure, you've always got a heart murmur, and it's a higher score, which I'll go through. When you're listening to their lungs, sometimes, and again, this is a bit subjective, both of their lungs can sound pretty bad. They can have crackles, especially when you've got severe pulmonary edema. The difference in breathing rate and the difference in the degree of dyspnea. Heart rate sometimes is another key one. The airway disease guys, they can kind of have any heart rate. Sometimes they have a really low heart rate because of increased vagal tone from their respiratory disease. With the congestive heart failure, it's normally never low normal. So sometimes it can still be normal, but it's not the low end of normal for that size dog. Again, airway disease, a sinus arrhythmia can be quite common, whereas that high vagal tone and being able to generate a sinus arrhythmia in a congestive heart failure patient is never. So when you're grading your murmurs, this is something I found quite handy. It's just to be able to quickly, sometimes it's a bit subjective as to where you're putting them. The grade ones are when you put your stethoscope on and you kind of not quite, when you immediately put it on, you don't hear anything obvious. You have to go hunting a bit, spend a little bit of time. Sometimes you're closing your eyes, which is what I do, to concentrate, and then you can pick it up. So that is a low grade. Grade 2 is soft, that is audible. Once but you pick it up a bit quicker than the grade 1s. Your grade 3 is immediately audible. And then your grade 5 is you're starting to get that palpable thrill. Grade 6, the little whole dog's almost shaking. So in your respiratory patterns, when you're looking at your rate and effort, respiratory rate is probably one of the earliest signs of mild pulmonary edema. And it wasn't until I worked with the cardiologist, really in a referral setting, that I've truly seen and appreciate how sensitive a resting respiratory rate can be to early signs of edema, and how owners who are very astute and used to counting breathing rates all the time, if you train them well and empower them, they can actually pick up on pulmonary edema before that dog's getting into trouble. So this can be great for doing dose adjustments in your chronic management, and having owners know when to bring them in or know when to contact this before they end up like poor little Benji and really in trouble. So if it's rapid and shallow, sometimes cardiac, the chronic airway ones can sometimes have more of an inspiratory effort, but that's not all the time. And the ones who are a bit harder are when they've got both and you don't know which one is the main, or are they both contributing to their respiratory signs. Another note that the cardiologists have really made me take home is coughing is rarely caused by pulmonary edema. It's normally that airway irritation or collapse. But I do see those ones that have got themselves a congestive, the acute pulmonary edema ones. There will sometimes be a soft, moist cough. So it's not black and white, and especially if they've got such a big heart that they're getting collapsing of their main stem bronchi, that'll trigger them to cough. But broadly speaking, you're more likely to have coughing. Severe coughing kind of points me a bit more to airway disease versus a high rest rate is pointing me towards pulmonary edema. So we teach the owners to count. There's all of these different apps. There's a few different ones that step them through, and they're nice because they get all your breathing rates in the one spot, and they prompt the owners, and the owners kind of quite like keeping diligent tracks of these. So if we've got little Benji coming in really in trouble, I'm not going to leave little Benji breathing like that while I go and talk to the owner. We're going to get them on oxygen if you've got oxygen cage or a quiet environment. They're not going to be left alone, and because they've normally had a stressful car trip in or got here somehow. So often a quiet environment and oxygen can have them really improve without doing anything. So Benji had a rest rate of 80. There was a heart rate of 160, and I had a grade 5 heart murmur, and there was crackles bilaterally. From the history, it was pre-existing heart murmur, but with this acute onset of a soft cough. I was starting to think more cardiac, and we began stabilization. So just going into the pathophys, I know it's a bit heavy at this end of the conference to be going through heavy stuff, but that acute congestive heart failure. So you think of your mitral valve disease, you're getting regurgitation across your mitral valve, increase in your left atrial pressure, then you're getting pulmonary venous congestion and alveolar flooding, and that's how you're getting your hypoxia. The sympathetic nervous system all kicks in, and that's a bit of a vicious cycle with an increase in heart rate and anxiety. So sometimes sedation and oxygen in these guys in this first bit and your diuretics really helps you break that cycle. So another step through is you get that leaky valve that's slowly getting leakier and leakier. Or you suddenly rupture a chordae tendineae and suddenly get changes in your pressure gradient, increase in your left atrial, in turn increase in your left ventricle pressure, and that's when you're getting then your pulmonary edema through your kind of backlog through to your left atrial pressure will rise, your pulmonary venous congestion, and your capillary hydrostatic pressure getting pulmonary edema. So in the first 10 minutes for Benji, we're going to go oxygen and sedation really before anything. And that is the difference in these little patients when we take that edge off can really help them. We're not going to pin him straight down for an X-ray or putting an IV catheter in. I've seen these dogs arrest if we do too much with them too quickly and too stressfully. Because we're kind of with him, I have a very high suspicion. Our cardiologists are quite adamant, wherever possible, if we can get that first diagnostic, a chest X-ray, even if it's only one view, to confirm the pulmonary edema, because if he had pulmonary hypertension and we go and give a heap of furosemide and then take our imaging and get a chest X-ray that has no edema, we don't know whether the edema was there to start with and we've shifted it, and especially when there's mild edema, you can move it along quite, with a couple of doses of furosemide. You take your chest X-rays, and the cardiologists don't know whether they were treating pulmonary hypertension or pulmonary edema, and they get quite cranky at us. In saying that, I work in an emergency where sometimes that's all well and good. It's the middle of the night, they're not anywhere to be seen, and we've got a patient that looks like it's dying. So we will, I kind of say to our team, if you really got a high suspicion that it's pulmonary edema, and the patient is critical, we can't get them to get that first X-ray, we may give our first dose of or if we've got our imaging and then I still want to get my first dose of furosemide in, we often do that off the needle is the other thing to minimize stress. If we don't have, and if you can't either get IV access or you can't, IM furosemide is still effective, it just takes a little bit longer. We give them butorphanol, so we should have changed that order around. I generally sedate them first, then followed by furosemide. Is butorphanol, I give 0.1 to 0.2 mg per kg. And again, if you can sneak it in, and often too, we give this subcut or IM as they go into their oxygen cage. Plus or minus low dose of acepromazine can help with your preload. We'll be reassessing our breathing rate every 10 minutes. Sorry for those who are clicked through that one. And you'll be watching these guys really carefully. So we've kind of got oxygen, sedation, plus or minus that first dose of furosemide, depending if we've got our imaging done yet. So simple oxygen options. I went through these in one of my other talks. I'll briefly go again. If you've got bottled oxygen, you get a regulator, just an oxygen, a little regulator and a bubbler, and you can run that line out and go into a cage. These guys are generally too stressed for nasal oxygen, and we're getting them in cage oxygen. The concentrators, there are some concentrators that can produce up to 10 litres per minute, but generally a lot of them are only 5, so you either need a couple of them to generate enough oxygen for a little oxygen cage. But it may be an option in a place, if you don't have easy access to oxygen. Oxygen bubbler, your little so you've got a regulator on your bottle, and then you've got a bubbler, and then you've got your line coming out. Different enclosures, and you can jimmy up all sorts of options from a cat carrier size. You can buy the Buster, the plastic ones with the clear kind of plastic over them. And you want to make sure you're getting rid of enough CO2 and that they don't get too hot in there. So we had popped Benji into oxygen. His rest rate went from 70 to 55 with just being calmer and on oxygen. So we'll step through radiographs now and the difference between normal and congestive heart failure. So in your left atrial enlargement is a hallmark. You kind of want to be figuring out if your left atrium's enlarged in however we are imaging them, from X-ray to ultrasound. In your DV and your VD, you're getting a bulging at the 2 o'clock and a straight caudal border. I'll show you the you've got a bulging is abnormal, a straight caudal border is normal. Lifting and collapse, when you get quite a big heart, you'll get collapsing and lifting of that trachea. Pulmonary veins bigger than your arteries. Versus more chronic airway disease, sometimes you're seeing more of a bronchial pattern, whereas with the pulmonary edema, you're seeing an alveolar pattern. So when are we going to actually push them a bit to, well, not push them, you hope not to, but when do you feel we could add our diagnostics? Our rule of thumb is once their breathing looks like it's not critical. If they still look like they're going to die if we take them off oxygen briefly, we're not going to move them. We have portable oxygen to move them to X-ray. And the thoracic radiographs are really the most sensitive for pulmonary edema. You can do point-of-care ultrasound and look for B lines. However, we have been caught where sometimes they've got mild pulmonary edema and we're not picking it up. It's just not quite as sensitive. It's still a good option. You don't have to move them. You can come to the bedside. And so sometimes our team will be doing a combination. We don't use pro-BNP as much because we do, we've got cardiologists, but it is something that our emergency team do use occasionally. If you're really stumped, you can run a pro-BNP. I'll run you through some of the limitations of it. So this is normal. When you're looking at your cardiac silhouette, you're kind of imagining where your left atrium is, which I've highlighted here. This is a normal heart. You kind of get the nice weight, the nice cardiac silhouette. It's not bulging up in the top there, and it's kind of nice and straight. Versus when we've got, hopefully this will work. Again, this is kind of where the left atrium sits on your DV and your lateral. When you see that bulge kind of coming out up the top, and sometimes you sometimes think it's actually pulmonary edema when it looks really white up at the base of the heart there, but really pay attention and that will be your left atrium. So your left atrial size, generally when you do have airway disease and concurrent, an underlying cardiac patient who may be just grumbling along but still not gone congestive. So you can have an enlarged left atrial side if you've got airway. To be congestive, you've got an enlarged left atrium. In the airway, guys, your pulmonary parenchyma is either normal, or sometimes you get a diffuse interstitial or bronchial pattern. Whereas once you're congestive, it's that alveolar fluffiness through the chordodorsal area. Pulmonary vasculature is normal in airway disease. Sometimes it can be a bit subjective. It's a bit harder to definitively pick up on when they're congestive, but it can either be normal or dilated. Versus, again, this is something where if you've got airway disease and congestive heart failure, you can have both, but if you've got one or the other, generally in airway disease, your left main stem bronchus compression, it definitely can happen. Versus versus pulmonary edema, unless you've got airway disease as well, you don't. So just showing the compression of that left main stem bronchus. So measuring vertebral heart score, this is something we can do off x-rays. It's a good start. It's something you can definitely do. There is now more sensitive ways of measuring the left atrial size off an x-ray, which I'll go through with you. For step by step, you're going to measure from the cardia to the cardiac apex, so from kind of the base of the heart down to the apex. You're going to draw a straight line from that. You're going to get your bit of paper. You're going to measure how far that is, and you're going to count from the T4. You're going to count how many vertebrae do we take to make up that brown line. Then you're going to have your short axis. So your short axis is the widest part at the heart. You want that line perpendicular. That's your short axis, and again, you're going to count how many vertebrae from T4, and you add them both together. There's a lot of variation in normal in different thoracic conformation and styles of breeds, but generally anything over 10.5 is abnormal. So yeah, this is just stepping through the final steps of measuring from T4 and adding them together. The limitations of breed variability, positioning, if they're slightly rotated, doesn't tell you why the heart's enlarged. So this could be enlarged with pericardial effusion, and there's non-cardiac factors that can affect the measurement. And also different, between two different people measuring it, you can get slightly different variabilities. So is there something more accurate if all we've got is x-ray to determine if we've got a big left atrium and we don't have ultrasound? This paper is actually out of our cardiologist. So Chris Lamb was a resident who's now a specialist, Brad Gavigan and Fiona Myers, who both trained out of UC Davis. So there's the different ways of measuring. We've got the classic, and I'll give you a copy of this paper in your notes. You've got your classic vertebral heart score. The top two are kind of what we're going to talk about is you've either got the vertebral left atrial size, which is measuring just from the cardia. So it's a right lateral radiograph. They're measuring from the cardia across to the caudal border of the left atrium. So you're kind of thinking, is it a more subjective way, more definitive way of measuring whether we're seeing a bulge there or not? So then you're going to measure this across from T4, and it's the vertebral left atrial size, and the general cutoff is 2.3 to 2.5. Our guys actually looked at the modified vertebral left atrial size, where they added an extra measurement because it's then trying to get you a 2D measurement of the left atrium. So you're measuring from your same one as what we just went through, so from the carina to the caudal area, to the caudal border of the cardiac silhouette. And then you're going to have that 90-degree line to the top. Sometimes the x-ray is not showing up that clearly where you can see the top on this, but normally when you're actually looking on the x-ray, you can see where it is sitting. and you're going to add these two lines together. And this was found to be more sensitive of left atrial enlargement. So 3.4 to 5 is suggesting greater than. So putting these all together, and this is something you can do. You can do all of them, and if all of them are enlarged, then that's much more likely to kind of say, right, we do have left atrial enlargement. The mainstay of diagnosis for us is echocardiogram. Who feels confident doing a left atrium to aortic ratio with the ultrasound? Yeah, good, a couple of you. So this is something that's practice. And even still, some of if you're not doing it all the time, it can be easy to be not good at it, really, I guess. So, but you're measuring the aorta to the left atrium, you're making that into a ratio. So you divide your left atrial size by your aorta, and greater than 1.6 is a sign of an enlarged left atrium. So it's the right parasternal short axis view, which you could teach yourself how to do this with some. There's lots online. You're going to freeze the image, make sure you're mid-systole, and this is when the aortic valve leaflets are opening and the aorta's at the maximum diameter. Oh, we'll go again. And then that's the inner edge to inner edge, and you're measuring that short axis. And then you're measuring your left atrium from the inner wall of the left atrium to the inner wall of the aortic wall on the caudal aspect. So if you don't have access to either of these imaging modalities, your next best in your hands could be a measurement of proBNP. It can be quick, it's minimally invasive, and it can help piece together information. It is limited by renal disease, other systemic inflammation, endocrine diseases, so it can go up for other reasons. And there's a grey zone in between in your reference ranges, and it's not a replacement for determining your increased left atrial size by the other ways, but it's a marker of an unhappy heart and release of these biomarkers. The ACVIM consensus statement, which again I keep referring to these, but these are great. There's the cardiac, the mitral valve one is a great resource, and I'd highly recommend. These are all open, free access, but it's not recommended for serial monitoring. It's only in very specific cases that trends can help you. So if we're trying to diagnose congestive heart failure without imaging, and sometimes we do, and we've got general practice vets in Australia who, may be diagnosing off a physical exam and history, and if they improve on some oxygen and furosemide, that's kind of like a treatment trial. This isn't ideal, this is not best practice, but it's the next best if that's all you have access to. So Benji had thoracic x-rays, we could see pulmonary edema, and the emergency team had run a proBNP, which was elevated. So furosemide is our mainstay of treating pulmonary edema. It's a loop diuretic, and we're using it when congestive heart failure is suspected. I'm going to give you our dosing, which it doesn't mean don't black and white change. If you had a dosing regime that's been working and all of your team are doing a similar thing, keep to it. Our dosing, our rule of thumb is if they come in and they're in trouble, they're going to get 4 mg/kg 2 hourly until their breathing rate is starting to improve. Some of those really congestive ones, like Benji, may actually need 4 mg/kg 2 hours apart. So it's a total of 12 mg/kg in 6 hours until that breathing rate starts coming down, and then we start titrating back. So once their breathing rate has come and has decreased to once it's less than 60, so when they're really, really high, we're going that aggressive 4 mg/kg IV or IMQ2. Once their breathing rate drops, we drop to 2 mg/kg 2 hourly and give a couple more of those, or we extend out the time and we go 4 mg/kg for another 4 hourly dose and then reassess, and often you're kind of catching up. Their breathing rates are coming down. We're counting their breathing rate. Once they're, in hospital, that first bit we're counting it quite frequently, but then it's every hour we're counting them, every half an hour if we're really worried about them. And we're getting our nursing team to catch them when they're asleep and resting, and we know it's a true resting or sleeping. If we mark whether they were sound asleep, which is the most accurate, or if it's a resting respiratory rate. Sometimes if they're up and anxious, you'll get a high respiratory rate, and that's not reflective of what's truly happening at that lung level. So you're looking for a decrease in the rate, and sometimes in that first, once we're giving diuretics, it's as quick as an hour. They're starting to improve. As I said before, there's that get out of jail free where we kind of got the leeway that we may give one dose of frusemide before, but we really want to confirm we've got left atrial enlargement and pulmonary edema before we just keep giving frusemide without confirming our diagnosis. The kidneys, we always run a biochemistry on these on admix. We want to know where our kidneys were sitting before we go and diurese them aggressively. And kidneys, we then continue to monitor. They get rechecked the following day. So our congestive patients kind of come in. They get that aggressive-ish for frusemide, depending on each individual case, that first afternoon and into the evening on oxygen. We would have already done their kidney profile as they were, at the beginning. And then we're rechecking their kidneys the following day. Because sometimes in these little old dogs, it's a balance between enough frusemide to dry them out, but if we're too aggressive, we can tip those chronic, they were underlying kidney disease, and suddenly we've tipped them into trouble with their kidneys. If there's no improvement, you're rethinking, what's my diagnosis? Is it respiratory or cardiac? And my other key point often now, emergency vets will can sometimes, it's easy enough to overlook. You go into a protocol-driven kind of practice and you give these 4 and 2 mg per kg doses of frusemide, but this is a chronic congestive heart failure patient who they're being managed on 5 mg per kg of frusemide 3 times a day, and then we go and give injections of 2 or 4 mg per kg, and these patients get worse in our care because we are underdosing them. So you've always got to look at what dose of frusemide are they already on, and they've gone congestive on that dose. I know I need to give more, especially in the acute setting, and then I know I need to up my dose when I'm going home or start adding in other, we'll add in spironolactone or thiazide. So that's kind of out of the realm of this talk. I'm more doing the acute management. So little Benji started to improve after some frusemide. Our breathing rate was coming down to 40. The other thing is we're starting pimabendin, and my mainstay for pimabendin is we have IV pimabendin, which I've heard you guys don't have it IV over here. So our really critical congestive heart failure patients that are so dyspneic that we don't want to be tableting, we will give an IV dose early on, but otherwise you've got to wait till they can tolerate oral meds. So they may still be on oxygen. We don't wait till they come off oxygen, but we're getting in pimabendin sooner rather than later. An ACE inhibitor, we don't start in that acute setting. We're waiting to make sure how their kidneys are coming out the other end. But if the cardiologist, and this is by the time they're out of ICU, and they come back for their recheck a week later to have a biochemistry, and if their kidneys are coping okay, then they normally add a ACE inhibitor then. If they've been previously on heart meds and they come in congestive and they've got an ACE inhibitor in their mix, we stop that in the acute period because we do want to look after those kidneys. Then the key thing is continued monitoring, rechecking renal functions, having that owner really aware of how important tracking respiratory rates are, especially if we're trying to avoid them being a frequent flyer in and out needing oxygen and IV diuretics, having them be very astute and noticing any changes in trends. Transitioning to home care, we're going on to oral frusemide. Else, if they've a naive dog, never been diagnosed with congestive heart failure before, our starting dose is 2 mg per kg orally twice a day. Once the if they're kind of getting towards more end stage, we're actually, they're getting up much higher doses and 3 times a day medications with frusemide, and as I said, other meds being added. That initial period, we get them back in a week, and then sometimes they're followed up anywhere. Depends how they go. They might need another recheck in a week, and then they kind of go monthly to 3 monthly, depending on how they are and where the owner's at. But you'd rather look at these guys more frequently than not. So the non-responders, think again, have we got an arrhythmia? Is there a PTE? Is there pulmonary hypertension? All of these things start coming to mind. So stabilize first, oxygen and sedation, low dose sedation. We don't try and floor them. Respiratory, cardiac, or both. So don't, just keep an open mind when you see those little dyspneic dogs. Frusemide, definitely trying to get your pulmonary edema diagnosis and before giving frusemide, but sometimes we do give that first dose to get them a little bit more stable. Don't withhold, if you're going to be sending a patient for imaging, that's my other, if they look like they're really in trouble, probably one dose of frusemide before they're heading off to a transfer to another clinic would be indicated. And then reassessing them often, breathing rate, effort, and what their kidneys are doing. So radiology, that I'll send you that paper on measuring those two, and it steps you through them quite clearly on measuring how to actually quantify the left atrial size, or getting your skills up and confidence up with a bedside echo and a left atrial to aortic ratio, and then know when to get them weaning off oxygen, coping on room air, onto oral medication and home. So our congestive patients normally have 24 hours in with us. They get dried out into that evening. They come off the following morning, they get a repeat blood test, a repeat chest x-ray to reassess our degree of pulmonary edema, and they get weaned off oxygen and home. The really, really wet lungs, so ones that are really in trouble, or they've ruptured a cord and so they're more acutely in trouble with much more fulminant edema, we sometimes need 48 hours to dry those out slowly. This is something I was going to put a video in. This is something I thought, these little dogs, we're kind of saying to these owners, this is a progressive disease. We're going to continue to manage it medically until, sadly, this disease process will probably be the end of them, whether or not their kidneys hang in. We're now very, very fortunate to be able to offer mitral valve repair. So we're not replacing the valve, we're actually repairing this mitral valve with the Jasmine group from Japan. It's open heart surgery. And initially we've done 5 cases this year. We only started at the beginning of this year, right before I went on maternity leave. And I was initially a little bit dubious of thinking, how much are we actually putting these little dogs through? Is this the right thing to be doing? Now that I've seen how these little dogs recover and they come off cardiac meds and they go back to normal cardiac function, it's life-saving. It's hugely expensive. We're flying out a team of 5 people from Japan. But this is something that these little dogs get a whole new lease of life. We've got a very good success rate of 100%. All of the little dogs have lived. And it's truly like a point in my career where I thought this disease process was terminal. We now have treatment options. And yeah, it's amazing. All right. Couple of minutes for questions, unless we want to do questions just all at the end. We get through. My little guider, what do you want to do? Because some people might be wanting to get going for flights. Do we just get on and then do questions so people can leave? I think we might do that. Well, what we might do, go.
Yeah. So for aortic thromboembolism cases, you have any experience with thrombolytic drugs like TP or streptokinase?
Yeah, so this in cats you're talking about?
Cats.
Yeah. So again, for a little while, this was years ago before I actually was there, they were trying that and they had varying success. So it depends how acute it is. And I think in human medicine, when they acutely have them and they can go and lyse those clots, they have a good success. If we've caught it and it's been delayed, you can have quite a catastrophic dead cat. So we don't, our cardiology teams don't, we treat them supportively. I don't think the evidence, there was a little bit of a push again to re-look at this a few years ago. And to my knowledge, the evidence is that it's probably got more risk than benefit, because generally with supportive care and time, those cats can come good. So are you guys doing it or?
No.
No, yeah. I think it's true.
Generally, they present after 6 to 12 hours
Yeah.
duration, so not in acute cases.
Yeah,
So
no,
we do not consider it.
no, we're similar. So it's treating that, diagnosed generally, most of the time they've got underlying cardiac disease. So finding out that, keeping them well analgesed, and we're using low molecular weight heparin and clopidogrel, and then we transition to rivaroxaban orally they go home on both. And so that consensus guidelines on the use of anticoagulants, it'll go through the treatment, the current best practice treatment of fate and use of drugs in these cats.
And one more question. In CHF cases, at what dose you prefer for torsemide?
For which cases?
If there is a refractory CHF.
So refractory, look, it's really hard. We will keep going with that 4 mg per kg. If they're really critical, I'll give a 4 mg per kg hourly for a few doses. The best way to get diuresis is actually a furosemide CRI. So if we've got a patient that we actually are having to ventilate for congestive heart failure, is we will go on a CRI, which I think I had the dose rate in there. I generally go and look it up. I don't do it often. The reason we don't put every patient on a CRI is because sometimes the nurse to get the CRI pump, make sure it's all made up, make sure the CRI is constantly running. There's sometimes variables and they get underdosed. And so in our hands, our protocol, the cardiologist and our whole team, we set a timer for every 2 hours. So we know that diuretic is due and we just know it's getting in. We're not umming and ahhing with different CRIs and accuracy of those pumps, especially in the small volumes, because you don't want to dilute out your CRI of furosemide too much because then you're giving more volume. So some hospitals will have a different protocol of giving furosemide. It's titrating to effect. And those refractory cases, we are sometimes pulling out thiazide, which just strips the sodium out of them and takes the water with it. It's an aggressive diuretic. Normally it's pretty end stage, and I've seen the kidneys go pretty quickly after we're doing that. So sometimes we're kind of prepping these owners of these little hearts are progressive, and we're not treating the underlying cause, we're band-aiding it. But you just keep titrating up.
Do you switch to torsemide, or you don't?
To which?
If they are not responding to furosemide CRI or max dose of furosemide, so do you switch to torsemide?
To which? What's the drug called?
Torsemide.
Torsemide. We don't routinely. So no, we use spironolactone or a thiazide generally, but yeah, I haven't had much experience with that one. Yep, one more. Yep.
Are there any more questions? Yes, over there.
What medication orally you mentioned for fate to send them home on?
So fate cats are going home on clopidogrel and rivaroxaban.
Okay.
So yeah, and I think there's the latest fat cat study as well. But in hospital, we're giving give low molecular weight heparin. So we have dalteparin because they're normally sick and oral meds, and the clopidogrel's really bitter. We put it in a capsule so they don't taste the bitterness of it. But yeah, clopidogrel and low molecular weight heparin. So we're working on the platelets as well as the clotting, as well as your factor 10A. Yep.
Thanks.
Anyone else?
One more.
You said the first thing what you do is usually give sedation and oxygen followed by furosemide. Do you also have focus on giving any antihypertensive drugs on the first go?
Yeah, good question. So this is something where, and again, for systemic hypertension, no, but acepromazine will vasodilate them a little bit and decrease their afterload. So that's one thing. That's why the cardiologists are kind of quite happy for us to use a little bit of acepromazine. We're not giving any other antihypertensives. But often it's all there. The body is kind of activated your RAS, everything's happening for a reason, and as you treat the pulmonary edema, that will resolve. With pulmonary hypertension, a lot of these guys, once they've got left congestive heart failure, you've got pulmonary hypertension as well, but when you clear the edema, the pulmonary hypertension goes. So the cardiologist will be monitoring if it doesn't improve, and then they may end up on sildenafil, so Viagra, but generally we clear the pulmonary edema first.
Okay, but acepromazine won't reduce the respiratory rate. Can it be sometimes a problematic thing for the patient who's sensitive?
No, a very low dose. So if they're sitting there, if they're not stressed, we're not sedating them generally. But if they're really, really stressed, we're unable to, we want to get an IV in so we can give frequent furosemide IV without restraining them. Sometimes just a little bit of sedation takes that edge off, but you saw 0.005. It's like half the low end of the dose, giving just a really little bit.
So butorphanol and acepromazine can be given intramuscular so that it can act slowly.
Together, yeah. We sometimes give a little bit low end dose of both is quite nice.
Thank you.
Yeah.
Hi. So the question is from GDV.
Yep.
How do you manage septic or inflammatory peritonitis?
Yeah, so good question. I know we were trying to chat before in the break. This is something, if they have ruptured and they've got a peritonitis, when the surgeons go in there, they're going to see that. You're going to have to resect what you can. That's the one time you do lavage. I know Chris said he doesn't routinely lavage. You're going to lavage that abdomen. It's going to be treated like any other septic abdomen. We'll put a Jackson Pratt drain in because we want all of that soupy inflammatory mediators the body to be able to get rid of it. And we've had ones where there's been chicken necks floating in the abdomen. Probably 2 Jackson Pratt drains, those closed suctions, and then you're treating them like any other septic abdomen. So appropriate IV antibiotics. And like Chris said, he doesn't go off the culture from that last, the post-lavage sample. We'll go with broad spectrum empirical, so depending on what you see in your hospital or what you're more likely to use, we'll use amoxicillin, clavionic acid, plus or minor. We try not to use as much N-rofloxacin because we're selecting for resistance. And if you've got source control, you've lavaged, and then you've got your drain, we're hoping the body can then deal with that, but we will either go amoxicillin, clavionic acid, or cefazolin. And then it's monitoring. It's just all you say, monitoring of watching your trends, we're looking at blood glucose probably a little bit more often because they're at risk of going septic. You're watching your blood pressure. You're supporting everything and hope that that body can heal and turn around. Sorry?
Without steroids?
Without steroids. So steroids is something where I know it's tempting to give them. You think it's going to cause, to get rid of any inflammation. Steroids aren't friends with your gut blood supply, so you can cause gastric ulceration even with low-dose steroid. We've already got gut that's compromised. There's no study that shows an improvement in outcome, like in the cases given steroids for, say, septic peritonitis or GDV, and it can do harm. These patients, we don't want to immune suppress them. It can affect their coagulation. It can make them more procoagulant. So there's a lot of harm that can be done with steroids. I know we like to think, and sometimes you get away, if you're just giving a one-off dose and you're not giving a massive dose, you probably get away with it and you think it's helped, when actually if you hadn't give it, the patient would have got better anyway as well. So just try, and sometimes it's tempting, you want to, but I guess I challenge you to, maybe not give it next time and see if because definitely in our hands, there's only a select it's like times we're using steroids.
So there was a patient who was admitted in the clinic for a month, and he got GDV, then he got discharged, then he got splenic necrosis, then we operated him again,
Yeah.
and after that he was admitted for a month, and I was not using steroids for the starting days, and his peritonitis got worsened. But then I started using steroids, and he got better.
Yeah,
So,
okay. And what else, how else were you treating the peritonitis?
I've tried multiple antibiotics,
Yep.
like starting with Enro, Metro, and I've started giving meropenem also, but again that was not working. The RBCs and hemoglobin were getting low, so I've stopped that and continue with the enrofloxacin and add steroids at prednisolone, and it worked.
Yeah. So look, and sometimes it kind of gives you that, they will if they weren't eating or they're not, sometimes a little bit of steroids makes them perk up, but I think longer term I really would avoid in those cases. Appropriate source control, so getting rid of any necrotic tissue that's in there and the right antibiotic will be the best treatment. So, yeah.
Thank you. Anyone else?
Do you have any thoughts about SGL2 inhibitors in case of HCM?
Oh, sorry, got you to repeat it.
It's SGL2 inhibitors. SGLT2 inhibitors. So usually it is used in case of diabetes mellitus in animals, and in human cardiology also we use. So there is some articles I have read which can be used off-label in veterinary medicine. So do you have any?
Yeah, I don't, to be honest, that's out of I haven't heard and not exposed to, so yeah, I couldn't really comment. Sorry.
Okay, sure.
Yeah.
Anyone else?
I have a question.
Yep.
So there was an article I read about using pimobendan per rectal.
Yep, for what?
Pimobendan.
Yep.
Since you can't give it orally in emergency cases like this, that they have used it per rectal. And since we don't have the IV preparation,
Yep.
so do you have any, as in, experience?
So yeah, per rectum for, yeah, look, we don't, because we've got IV. I don't know the pharmacokinetics of it to see how it's absorbed, but if there's a paper that's saying they're doing it and it's effective, we do use a fair few other things per rectum. It's a good option. You've got good absorption. So if there's a paper showing you that it is absorbed, the only thing is just what's more stressful, something up the bum or something down orally. So generally if you get it, wherever you can get it without stressing them, but I'd double check that it's definitely absorbed per rectum. Yeah.
Thank you.
Yes. So one more question. So in case of leptospirosis, so we get this patient where already the creat and bun shooted up to almost 13, 140, and the liver is also compromised. Should we do a dialysis in these cases? And CRP, we have run the CRP, C-reactive protein, so it has come elevated. D-dimer is also elevated. In these cases, can I consider PRED and go ahead with the dialysis?
Yeah, so I guess, so is that for treating leptospirosis? Your question is whether you would use PRED if your CRP is going up and trends. Look, again, I don't treat lepto. We do get lepto right up the north of Australia. I don't commonly treat it. The mainstay is getting your antibiotics into them and killing that. I don't know about that secondary effect, whether some anti-inflammatory of the steroid, whether that may be a select indication. The default out there, yeah, I'm not 100%. Sorry. It's a medicine out of my realm.
Okay,
Yeah.
thank you.
Do we have any more questions?
Yes. So do you use furosemide for the patient with pericardial effusions?
Yeah, good. Right, look, good question. Long and the short, no. Depends if they've got a really small, trivial effusion from, and no, even then we wouldn't know. So yes, sure. The answer is no. Generally, those cases, if it's only mild, we're not going to drain it. If they've got pericardial effusion because they've bled from a heart-based mass and they're gone into cardiac tamponade, or like the rodenticide case, depends. If they're in tamponade, we're going to drain it. Otherwise, it's, yeah, you're trying to figure out why is it happening, and sometimes if they've got pleural effusion, pericardial effusion, and ascites, have we got a tricavity effusion? What other disease processes are going on? But we won't use furosemide per se.
Anyone else? Yes, sir, please.
Madam, it is advisable or safe to use hydroxyethyl cellulose in fluid loss
Oh,
or
sorry.
dehydration? Hydroxyethyl cellulose colloid solutions.
Oh, I haven't quite caught that. What was the question?
Hydroxyethyl cellulose, PET plasma.
Plasma, yeah.
It's a colloid solutions.
Oh, I'm sorry, I'm not quite getting the question. So using plasma in what cases?
Plasma. For fluid loss and dehydration cases.
Yeah, okay. So,
Blood loss.
yeah, blood loss or fluid?
Volume loss due to blood loss.
Yeah, so what I think the question is when are we using fresh frozen plasma for cases with fluid loss, whether it's blood? Fresh frozen plasma in our hands, we're using it when they've got a coagulopathy and we want to give those clotting factors back. Some of those patients that are really critical, they're septic, they've got low protein, they're right on the edge, their albumin is really low, their third space, they're getting very edematous. We'll use plasma in them at a really low CRI in combination with our crystalloids. So they might go on a CRI of plasma at 2 mils per kilo per hour for 24 hours, and a little dog might get a unit given very slowly. That steadily helps the glycocalyx, that low level of albumin, and it just helps. We put them on it, and their fluid balance, their urine production, everything seems to turn around slowly. So I will use it in those severe cases, or if I've got a really critical patient that's getting hypotensive and it's got really low albumin, and I know that any crystalloid I'm going to give it is just going to go straight out into my interstitial space, I might be more inclined to actually bolus it with some plasma. We really steer clear of the synthetic colloids now, and I'll use a natural, a FFP in that acute setting if I'm trying to stabilize a septic dog or something. I think we're a lot more pro using plasma for a lot more disease processes now. And if they've had blood loss, and I've been able to give them some packed cells, if they're actively bleeding, I want to give them packed and plasma back together. So yeah, definitely we're a lot more fluid, a lot more proactive with it.
All right, thank you so much, everyone. And it's a reminder that you'll be able to access the recordings of all the lectures on our official conference website. Thank you. And with that, I request Dr. Ellie to start her next session.
Right, this final talk, initially when Dr. Singh asked me to speak on snakes, I was a little bit hesitant because I was like, I know our snakes really well, and this is a massive area of passion and research for me. We've published out of ICU, we've published probably nearly 10 snake envenomation papers in the last little while. Sorry about the backwards writing, but I was trying to get ChatGPT to draw me pictures of our two different snakes having a fight. The plan for today is what I want to do. Well, one, I want to show you what happens. This is a CCTV footage of an eastern brown. And for us, we see a hell of a lot of snake bites. Our season is really ramping up at the moment. As soon as it warms up into our summer, we see snakes from probably August all the way through till March next year. Our dogs aren't the brightest. They keep going, and we see some massive venom loads. We've done blood venom levels, and we've been really looking at the amount of anti-venom. We've done a lot of prospective research. One of the highest blood venom levels we ever had was over 20 times the max venom level I'd found in the literature in an eastern brown human envenomation. And this is why. They just keep getting bitten. So they don't just get bitten once. So I think in veterinary treatment of snake bite, we're dealing with a massive load of venom compared to a human. Sometimes drunk men maybe get bitten a few more times, but for us, yeah, we see huge venom loads. In these dogs, this has often happened while the owner's at work, and they come home through varying stages of the progression of snake envenomation, and really down to individual species. And they're all slightly different, which I'll step you through kind of what ours do so you can see. The key thing for me for this talk is, well, I got a bit excited. I started researching it, and I did find out that your snakes actually do, sometimes there's a bit of cross correlation. Some of your venom components are similar. Some of your presentations, from me just reading the human literature, I haven't spoken to enough of you to really get a feel for how these are presenting in dogs. So please take what I say about your snakes with a little bit of grain of salt, because it's just me looking at the human literature. There's only 3 veterinary papers I could find, and they were really quite sparse and basic. So there's a huge area of need for the veterinary profession to publish more about these. I'll highlight the clinical presentations and treatment similarities so that when I show you a little bit of what ours do, there may be something you can take away from what we're doing that could help you. I don't know. But we see respiratory muscle paralysis, coagulopathy, and kidney injury are the big kind of mortality factors for us. The key thing for today is I want to kind of show you how we treat them. We call it the 4 pillars of snake envenomation. We go through how we triage and stabilize them, how we get a diagnosis, how we give our antivenom, and our treatment of complications. So again, I can't emphasize enough. I'm not here to teach you how to black and white treat your snakes. I'm here to kind of share a bit about how we treat ours, and you take what is relevant, because I would love to spend more time treating your snakes here. And then I want to really stimulate a discussion about what future opportunities for research, collaboration, and treatment advances are there in India at the moment. So you guys have the big 4. We also have the big 4 for our veterinary. This is the top 10 venomous snakes in Australia. Our big ones that we really have problems with our dogs are the eastern browns, the red-bellied black snakes, the mainland tiger, and the copperheads. So together these probably represent about 90% of our snake bites in dogs and cats. Whereas you'll hear, if you want to find out what the most venomous elapid is, it's the taipan. However, the taipan, where it is geographically located up the top of Australia, it's a lot more sparsely populated, so there's not as many chances for dogs to run into them, and we just don't see as many envenomations in those in the taipans. I want to show you what our guys do. These eastern browns. This is a dog who was envenomated. He walked in. You can see that little dripping of blood on the ground in our treatment area, and you can think, oh, he was bitten on either tongue or he was bitten, but he was actually having a pulmonary bleed. And eastern browns don't do this in humans, they do it in dogs, but we get fulminant pulmonary hemorrhage. And he was bleeding out. And this was in 20 minutes. So I was on this evening, and we were prompt. We got that dog in, we had a catheter in him. We realised, we'd done a coag test on him. He had a collapse episode. The owner had a dead snake as well, which always helps with your diagnosis. So we were really quick to bolus antivenom into him. And by the time I had the plasma thawed to be able to start, this is how he was. So in 20 minutes, he was arresting. Our eastern browns, kind of like your vipers, cause a complete consumptive coagulopathy. So their blood just doesn't clot. We run ACTs. From the literature, I saw there's whole blood clot time is really common. Is that how you guys check coax? Just blood into a tube, or do you run activated clotting times or PT-APT into an ACT tube like these? So these have got a medium in them, which we put in. Normal is less than 120 seconds. We've got a little machine that will warm them and count for the clot, but our snakes just max out at 1500 seconds. They just don't clot. We pull it out, there's no clot. If you don't have the little machine, you can run these ACT tubes just at body temperature. You just put them under your arm, and we keep checking them every 20 or 30 seconds or so. Oh, and then this is another fatal pulmonary hemorrhage. And again, these dogs often it's before they bleed out before even the paralysis can get them. So this dog had walked in, and within 1 hour, it had a fulminant pulmonary bleed. We were trying to get it on the ventilator, and unfortunately, it didn't survive. We have a neurotoxin, so the eastern browns are mostly presynaptic. So for us, once that neurotoxin is bound, doesn't matter how much antivenom we give them, it takes time to unbound, which I've seen some of yours have presynaptic, some of them have postsynaptic. So postsynaptic binding is reversible with antivenom, and their breathing will improve post-antivenom, whereas our Eastern Browns, and it normally takes hours for this to happen, so an owner wasn't aware, or they initially have a collapse and then they recover and they think they're fine, and then they don't bring them to the vet until they're then paralysed. But then by this time, we really need advanced support. This dog needed a ventilator to survive. You can see how paralysed he was when he was just trying to flick his little leg. They come in and they're literally like, you really feel sorry for them, because you can see they know what's happening, but they can't move a muscle. And that respiratory, I'll step you through more in how we manage the complications and how we recognise that they're in trouble with their respiratory effort. But our Eastern Browns need ventilation. They generally only need about 24 to 48 hours as the venom reverses. So they're really nice for us, especially that we've been able to, I feel like our skill in ventilation, because we have ventilating Browns, which were generally, unless they've bled into their lungs, so not only a small percentage do that catastrophic bleeding, but they're good to ventilate. Red-bellied black snakes, so these guys have a cytotoxic effect, and they break up red cells, so a hemolysin and a myotoxin, and it's the secondary effect of that pigmenturia, so myoglobinuria and hemoglobinuria. This dog's got almost black urine coming out of it that knocks our kidneys around. So do you all guys do the pigmenturia? Do any of them get this pork-coloured wine urine? No, so not as much. There was one of them that I saw listed that it may have done it mildly, but this is really classic for our red-bellied blacks. They also, the direct effect of the venom, we get spherocytes. We used to say, is this a delayed IMHA? And we used to fill them up with steroids. Our research, we've actually tracked these out. This is one of the papers we published, is this dog had spherocytes to 62 days. We didn't treat it with steroids and it got better. And so we now actually know it's a direct effect of the venom. It happens really early on. It's not a delayed immune response. So we support them with red cells if they need it, but they don't need immunosuppression. So there's a little spherocyte popped down into a circle, and this is where getting good at blood smears can really help you with your, being able to look at these, whether they're snakes or not. Just IMHA is how you're going to be diagnosing spherocytes. So spherocytes, the kidney enzymes increase in these, the muscle enzymes, because it's attacking the muscle, so we see a transient myopathy, and we get, oh, that's not lining up, we get progressive, we get very marked anemias in some of our red-bellied blacks because they hemolyse all of those, so we need to give them blood. The kidneys take a hit. Your guys have the direct nephrotoxin, whereas we have a secondary acute kidney injury. But either way, the kidneys are getting a hit. Our tiger snakes cause a venom-induced consumptive coagulopathy, and they paralyse them, and so they can need ventilation as well. That snake could cause megaesophagus, and sometimes they need prolonged support with feeding or peg tubes. That's on the ventilator. So I guess over to your guys' snakes. This is something where snakebite in India has been listed as a neglected tropical disease. There's a real focus in addressing this. This is all stuff I found online from researching. 50% of global deaths from snake bites are happening in India. It's estimated 58,000, but it could be more. It's a really rural problem of farmers and remote areas and seasonal. The World Health Organization has listed it a priority. It sounds like anti-venom, and is anti-venom to source easy for vets? It's got to pay for it? No. Yeah, no. So it sounds like your anti-venom, we work really closely with we've got the main anti-venom provider. We do a lot of research together with him. We did the clinical trials to get his anti-venom registered in Australia. He's amazing. I talked to him before I came, and he said from what he's heard is you have huge problems with quality of anti-venom because there's such a demand for it. There's been a real undertone of maybe some companies who aren't purifying and processing as well, and then that brings increased reactions. because antivenom's made from equine serum and also inferior quality products. So I really feel for you guys, because we kind of know we give a certain amount of antivenom and it's going to neutralize that venom, whereas I feel like it would be a lot more questionable over here with the quality and control, whereas World Health Organization, I think that's becoming a priority now to improve your guys' quality. So the big four, and again, correct me if I'm wrong, I've heard all people, a little bit we've chatted about this, of different areas of indoor where you're more likely to know it's the same in Australia, you know what species are in your area. But the Russell's viper, the common grout, your cobra, and your saw-scaled viper. And again, this is just from the literature that I've pulled up, but you're kind of looking at the venom, and I'm thinking, right, what neurotoxins have we got? We've got cytotoxins that are causing swelling. And it sounds like Dr. Singh telling me he had one that the tongue was so swollen they had to do a temporary tracheostomy. Seeing some of the necrotic limbs in pictures of human papers of limbs becoming necrotic and needing amputation. Whereas your vipers have really got your strong procoagulant causing your venom-induced consumptive coagulopathy. Do your guys bleed into their lungs like ours do? Where do they bleed generally? They don't bleed? No. So yeah, a different clinical picture, but there was some cross ones that I kind of thought, oh, that's quite cool how similar they can be. So when you put them together, when you actually list out the venom components, we kind of do have a bit of a cross. So our, neurotoxins, your cobra and creat kind of have got neurotoxins in them. Your vipers have got the venom, the procoagulant. The vipers were listed to cause, Russell's viper has a direct nephrotoxin, but also in humans it's reported a secondary AKI. Bite site swelling was reported in the cobras, and the antivenom, you have a polyvalent. We had, the human literature reported the same three big drivers that kill humans, as what were killing our dogs. So these different patterns of presentation, of looking whether they're paralysed, they're bleeding, are their muscles being damaged, their kidneys being damaged, or have they got bite site local necrosis. So to come back a bit, to go right more simply, it doesn't matter what snake we're treating, how are we going to treat them? We're going to triage and stabilise them. We're going to get a diagnosis as best as we can. And I'll step you through, we've slightly changed the way we think of our diagnosis in our snakes. We're going to get some antivenom into them, and you're going to watch for the fallout of what complications. The sooner you can get antivenom into them, the less complicated the knock-on effect that we have. So we really prioritise them. We have and I don't know, some of the bigger referral hospitals that I've been talking to people at, you may actually have a triage system where you have different coloured cards or coding as they come through. Ours are always red. They're a high priority, even if they're walking in and they look fine, because that's the window where if we get antivenom into them, they don't end up on ventilators or bleeding out. We do our, your basic stabilisation. We're getting them on some flyby oxygen and an IV in, and we're normally pulling those baseline bloods to get a coag on them. Coagulation testing is kind of our mainstay in our snake patients. If they're hypovolemic, so sometimes that initial hit when the venom hits them, they've now found, and this would be the similar, do yours do the collapse episode and then recover when they've been first envenomated? If you're nodding, don't know. No, they don't necessarily. So it's the venom, with our Eastern Browns, they do that. They hit the deck and then recover. It's a direct effect of the venom, and that causes a vasodilation. They used to think, was it all these clots from the procoagulant? But they now know that they just vasodilate and then come back. So some of ours turn up and you're kind of figuring out, are they hypovolemic? What's happening? We'll look at their perfusion parameters, and some of them it's indicated to give a fluid bolus. We're really prepared for rapid deterioration. Like I said, they can walk in and 20 minutes later they can be bleeding out, so we don't put them in a cage and ignore them. History, we're asking question, was it witness snake bite? Is there a dead snake? Are you living in a snake area? What clinical signs have we got? So the early neurotoxin, are they starting to get weak and paralysed? Can you see a bite site? So our red-bellied blacks, we sometimes see a bite. You can see the fang marks and a little drip. So paying real attention. Sometimes I'll even run the clippers over them. Be careful, because there's venom, and you can sometimes see crystallised venom on their coat. That venom is venomous. Like, don't mess with, like, I'm often wear gloves. Be really careful because the venom can end up on their coat. We're looking for, we get pigmenturia, so we're looking for port-coloured wine. Sometimes they're mildly dilated pupils or had a vomit for our ones. We're doing our in-house blood tests, so we don't have time to send anything away. We're checking our ACT, activated clotting time. That's the quickest and most reliable because it just doesn't clot. We're looking for anemia or hemolysis, especially in our red belly blacks. So this is what we're kind of doing. So take which bits of this would be relevant to your guys' snakes. And we may run a biochemistry to get a creatinine kinase to check muscle increase if it's got a myolysin in it. Note that like a CK on presentation for our snakes, just because it doesn't have an increase in CK if it's a snake with myolysin, doesn't mean that it's not going to come. It takes up to 3 days to peak for us. We do have snake venom detection kits, which we can run on urine. They are quite, generally if they're positive, they're positive. So they're good in that way. If they're negative, they may still have been envenomated. Either they've got very low circulating amount of venom or they've actually absorbed all of the venom and we're not detecting it in urine still because it's bound to them, so it's a delayed presentation. You've got error running this kit. It's a little bit fiddly, and it's specific for our species. I saw some in literature they were trying to have a mobile phone app that would, I don't know quite what they were trying to determine, but in this paper, they were trying to have a new novel way of diagnosing Indian snakes. Do you guys have any of these bedside tests, like snake venom detection kits where you can see which snake it was? No, yeah. It's something that there will be a way to figure this out cost effectively, but they haven't figured it out yet. It costs us about $500 to run this, and a vial of antivenom is $1,000. So we almost rather put a vial of antivenom into them. This is just a note, again, I just wanted to point out in the human, I found a paper with human Russell's vipers, 60% of envenomated patients could still form a clot at the 20-minute mark. But when they did their coags on them of PGAPT and other ways of measuring coags, they were coagulopathic. The whole blood clot time had clotted despite significant envenomation. And so if it's unclotted, it's reliable for a coagulopathy. But just to make a note, if you are running this whole blood clot time, if it clots, it doesn't rule out envenomation from this human paper I read. So don't delay. If you've got all these other signs of envenomation, I guess my big thing, and we're now leaning a lot towards being at least a bit more proactive. We'd rather give antivenom and give a vial sooner rather than questioning and then having a delayed presentation and potentially a dog that's not surviving. So this concept we kind of think of now is, what are my big ticket items for envenomation? And how many, and we kind of think the 100 points, in Australia we have to have 100 points to get an ID check, and your passport and your license and things like this are the big ones. So this is the kind of take on that, is snake bite witnessed, positive SVDK, really pronged cloacs, and low fibrinogen is a hallmark of venom-induced consumptive coagulopathy, or if we have acute progressive respiratory paralysis with the respiratory component. Lower down, which get a little bit more points, we kind of have an increase in CK. If they have that collapse and recovery for us, generalized lower motor neuron paralysis, which we have there's a list of other things it could be. If there's a venomous snake that's been found with a positive snake ID, so we have non-venomous snakes, so we've always got to do scale counts and figure out if it was venomous or not. They've witnessed an encounter, or if it's snake season and location. Versus some lower down kind of markers that all contribute. So if you've got a fair few of these all might add up to your clinical suspicion. Hypersalivation, vomiting, defecation, mild hemolysis, but that could be intravascular IMHA, a mild coagulopathy, that could be a heap of other things. Our red belly blacks cause spherocytosis, but again, so does IMHA. So again, we kind of trying to have our vets think a little bit more about what are my big ticket items, what am I much more likely to go, right, this is top of my list, I'm going to proceed with antivenom. Dosing of antivenom, and again, this is in Australia. I don't want to teach, I'm not here to teach you guys how to suck eggs, but we used to give up to 25 vials of antivenom. Over the years, it's slowly decreased, and the recommendations have decreased with new guideline updates, more research. We used to keep giving it if there was a coagulopathy, and we used to try and reverse the coagulopathy with antivenom. We now understand with venom-induced consumptive coagulopathy, you use up all your clotting factors and you're not going to have any reversal of your coagulopathy until your liver has time to make more. But it probably coincided, by the time you got 20 vials into someone, you could be 20 hours into treatment and your liver's making new factors, and you think that final vial was what turned your coagulopathy around when it actually was just time. We've come back down. The human guidelines now actually only recommend 1 vial. In veterinary now, and especially because we're dealing with some massive envenomations, we've looked at blood venom levels, and I feel very confident we now give max of 2 vials, and sometimes 1 vial is enough. So if an owner can only afford 1 vial, quite confident doing that. If they can afford 2, I know that 2 definitely from our research knocks out all venom. So you think of this venom-induced consumptive coagulopathy, you go back to your clotting cascade. The procoagulants can work at all different, they kind of come in and activate at different areas and just massively end up with a huge conversion of thrombin, prothrombin to thrombin by activating it, and also your guys' ones can act at the factor X and factor 5 activators. Ours are C and D, our elapids, whereas yours do act differently when I really looked into it. The end result, but is a consumptive coagulopathy. You get rapid consumption and your blood won't clot until your liver's making new factors, which takes time. We don't give more antivenom if the coagulopathy post-antivenom persists. I don't keep checking my coagulopathy if they're not clinically bleeding, because I'm not going to treat it with plasma unless they're trying to bleed out into their lungs, or sometimes they might have some bite. I've had them drip, drip, drip from the bite side on the ear, and we've dressed it, they just keep bleeding from areas that, even with pressure bandages, and if you can't get a pressure bandage, say on the ear, fresh frozen plasma may be indicated if you can't stop them bleeding. So we administer our antivenom as quickly as we can, and these are priority, and it's often that by the time you had a nurse or tech find a CRI, get it going, start it, we'll often do it with a slow push where we're staying with that patient and giving antivenom slowly. I give it over 15 to 20 minutes if I've got the luxury and they're not deteriorating in front of me, and I dilute it out with some saline. If they've come in and they've had their collapse episode and I feel like they're ticking time bomb to acutely deteriorate, I may give it quicker, where I'll give it over 5 minutes. I really want to start neutralizing that venom. We only give a max of 1 to 2 vials. We have 8,000 unit vials, and I don't want to make a recommendation here because it sounds like your antivenom can really vary in quality and purity and in neutralizing capacity. There's so how much antivenom do you give at the moment? Like, how does it come in vials, or do you give it 10 ml? And how many vials would you give to a patient? Sorry, what was that? Yep. And then would you give 1 vial or 2 or 3 or 2? 2? Okay, yeah, okay. And you find and then you just keep treating all the complications post, don't you? So that's kind of similar. We give max of 2, and then we treat the fallout, because we've done, and this would be something you guys figuring out if you've got someone to help you do this, we've looked at blood and urine venom levels pre and post every vial in a big group of patients. So we could see the envenomation levels pre-antivenom, and we check what they were doing after each vial, and that's how we feel confident in really culling down. We used to give, 12 years ago, I was giving 5 vials. You keep giving antivenom. We definitely don't do that anymore. Pre-medication, this is something for humans and veterinary. So the World Health Organization does not recommend routine pre-medication, which I might be going a bit against the grain. We used to pre-medicate all of our snake patients. But no drug, when you actually look at anaphylaxis models, no drug truly prevents anaphylaxis. So sometimes it's a false sense of security. You kind of go, oh, I've pre-meded them. I don't think they're going to get anaphylaxis. The only drug that, it's a reaction to your foreign immune protein, your immune response to equine proteins. But your risk really does depend on your antivenom purity. We've got very purified antivenom. All of the albumin has been taken and IgM out of it. We've just got IgG. So in saying that, here I don't want to say don't pre, because antihistamines and steroids, they won't work for anaphylaxis, that off the end of the needle, in trouble, hypotension, all of that. They may help with mild urticaria or skin reactions or delayed serum citrus. So if you've got cruder antivenom here, it may be indicated to still pre-medicate with these. I guess my thing would be to warn you is that the true fulminant anaphylaxis where you're dying off the end of the needle, adrenaline is the only drug that's really going to blunten that response and being ready. So adrenaline should always be drawn up. If you think how short-acting adrenaline is, so if you want to pre-med with adrenaline and you're only giving a one-off shot, it lasts a few minutes and it's gone. So the only way to really truly have them kind of, this is something true, if they've previously had a reaction to antivenom and you're really wanting to have them as safe as possible, probably putting them on adrenaline CRI while you're giving antivenom would be indicated. But it's focusing, we don't leave their side, we're constantly with them while they're getting antivenom. And as I said, we do get it in pretty quickly. Cats, we give it slower, we give it over an hour. We're still constantly with them. Cats, normally, we don't see them as much in that acute. It's normally they come in and they're paralysed by the Eastern Browns, and they're already bound presynaptically, so us bolusing in antivenom may have more harm than good. So the World Health Organization and this new, the Indian, it's a group that is, I've got it written out what it is, National I've got listed out what they are, but there's a 2024 group that they really want to improve your outcomes in snake envenomations. They really want to focus on antivenom quality, not pre-medication. But if you need an adrenaline CRI for any indication really, the cheat sheet I wanted to show you, which is a really simple way of getting it, it's quite a complicated formula and you're stressed and the thing's dying. You just get a litre of fluids, you add 1 vial of adrenaline. If you run that at maintenance, so 3 mils per kilo per hour, or if you went and figured out your drops per second for that body weight, it's called a dirty epi-drip in human medicine. But this is my mainstay. If I've got anaphylaxis happening, I'm going to have them straight onto an adrenaline CRI, and I'm not messing around with this. Is just in my head, and our whole team know how to do this up. So the last little bit, I just wanted to show you a little bit on how we manage complications, and then probably throw it open for questions and discussion. Respiratory failure, and it sounds like, do your guys get the dogs get paralysed enough to need ventilation? Is it the cobras that paralyse them? No. Yeah, no, so maybe not as relevant. We get generalised paralysis. The respiratory muscles are generally the last, and they get this really slow rate. The pattern can vary, but this is for, they really get an abdominal effort, get high CO2. Generally for us, if they look like they can't breathe, they probably can't, and this is how our Eastern Browns die. They'll arrest because of this. You can try sedation and oxygen, but to be honest, these guys need help with ventilation. It's not going to change. It'll maybe decrease their work of breathing a little bit, but it's normally not enough. So it's mechanical ventilation or hand ventilating. This is an Eastern Brown. And you can just see that real true, that I kind of call it the snake tick. They get this really flaccid, floppy. They're very different to our tick paralysis. Respiratory efforts, but this dog's just so paralysed. And this, even though he was keeping we had him on oxygen, she was keeping her oxygen and a CO2 just normal. This is what we would call an unsustainable effort. And I actually talked to this owner about going on the ventilator rather than letting this wait till this dog arrests. We'll get them hooked up, This is our ICU and a busy, we have tick and snake season right at the moment now, so we can have 3 or 4 patients on ventilators at any one time. That was a tick when they're clipped. This was us doing the team were about to do a lung wash on another tick and a snake. So I was showing around the rest of ICU. This is the same dog 24 hours, so the next day off ventilation, and you can just see that effort looks so much more sustainable. We're kind of leading with the chest a bit, we don't have that abdominal kick, and this dog's getting through the end of us. You know, they still stay, for us, they still stay paralysed for days. This is the other one I showed you at the beginning. But even though sometimes these rates are slow, this is a dog that's about to, close to arresting. Our venom-induced consumptive coagulopathy, so it again sounds like ours do something slightly different, but ours bleed into their lungs is the main area. We now have found, we used to think we want to sedate them so they don't cough and don't make themselves bleed. We now know that that cough is an early sign that they're bleeding. So if we have a coagulopathic patient with a soft cough, we go looking for it. We used to just sedate them down and then suddenly it's all pouring out and they're dying. This is an Eastern Brown that we were able to save proactively. Soft cough, walked in, chest x-rays of obvious alveolar pattern, and in a coagulopathic patient in that pattern, we were happy to say it was a pulmonary bleed. We gave rapid antivenom and then we had rapid plasma. We now in our snake season keep a unit of plasma thawed and in the fridge, because otherwise it takes about 20 minutes to thaw it. And this is for rodenticides or our snakes. We got to have liquid plasma ready to go. You need to be in a bigger, kind of busier hospital to have the workload to use it up and not waste it. So for us, antivenom will, neutralise what venom is still circulating, but normally the trigger of the coagulation cascade has already happened. We don't give further doses once we've given an appropriate amount of antivenom. We don't keep going for coagulopathy. That liver regenerates our clotting factors. And sometimes, look, the earliest, normally it's about 12 hours is the quickest I see a normalisation. But it can take 1 to 2 days. We kind of keep an eye on that. We'll give FFP if they're clinically bleeding. Again, this is human stuff, is some of them are still giving huge amounts of antivenom. It sounds like the veterinary profession might be already a little bit ahead. I'm not 100% sure, but they're really reflecting now on this National Action Plan for Prevention and Control of Snakebite, which was launched last year. The guidelines are now really encouraging really rational kind of use of antivenom and more supportive care, which it sounds like you guys are already doing. So secondary acute kidney injury, this is another this is a red belly black dog, and this is his kid. This dog didn't survive. We post-mortemed him and published. And this is, again, something we need to get out there, how your dog's actually presenting, what is the pathology. So even though if they're sad that they can't get through, but we can learn something for them, we get a post-mortem that we can get published. You could publish a case series on some of the complications of these. Our guys have acute tubular necrosis from the hemosiderin deposits and also myoglobin. Once they go oliguric or anuric in our hands, I haven't saved an oliguric or anuric red belly black. Do your guys, the kidney injury, do you guys get acute kidney injury in them? Do you get them, do they restart producing, can you get them through, or is it normally a death sentence? You can reverse, yeah, because you've got a direct nephrotoxin, whereas ours, it's all secondary. But the key mainstays for us are we avoid hypotension, we don't give them non-steroidals, we keep them on fluids, but we don't overhydrate, we don't underhydrate. We'll monitor our urine output, so often if we're worried, we put a urinary catheter in to watch them more closely. We'll track their blood creatinine. If if they've just got pigmenturia, I will actually have the team catch every urination and I'll watch for clearing and improvement. I just put that slide up. That's just an easy way to track. But normally if we're really quite worried, we've got a urinary catheter in. If our urine production is decreasing, we'll give low-dose mannitol. So we normally put them on a mannitol CRI. So it's 0.1 grams per kilo per hour initially, and then I halve it. And they may stay on a mannitol CRI for a day or so. The osmotic diuresis seems to really, this help for us. We're kind of trying to maintain fluid balance while we give those kidneys time. But once you PM these kidneys, there was no way those kidneys are coming back. And even if we could put that patient on dialysis, those kidneys weren't going to recover. So I feel we're just not compatible with life sometimes. But generally, initially, I get my hope up a bit. I still try. Is these guys often, their UOP improves on mannitol. There's a degree of osmotic diuresis where any acute tubular necrosis and the cells are all swollen and their polarities change and they're all unhappy cells. The mannitol may actually help to get rid of debris from those tubules and help actually decrease in any cell swelling in the kidney tubules. Whereas frusemide is just purely a diuretic, and sometimes if they're not producing urine, it doesn't even get to where it needs to act, so we just see no response to it. I sometimes just start with a titch. I give like a half a mg per kg. If I have no response in any improvement in urination, I give a big whack. But normally by this time, I'm telling these owners to stop and euthanize. These dogs die horribly. In humans, and with any kind of acute kidney injury from anything, but snake envenomation, they're dialyzing them much sooner. So I guess I'll finish up there and throw open to future opportunities and questions. In Australia, we have the snake bite map, which all vets can get trained up to the level of data collection, and we log our cases into this big kind of, I guess, a database. And then people who are actively contributing to cases can actually go and then write paper, look at a question and see what data is there, and go, right, are we going to write that up and write a paper? And so this is a real collaboration across colleagues and across different areas, because geographically, our eastern browns do slightly different pitches all up the east coast. There's different venom compositions even within the same snake. And this is all stuff that's probably happening over here as well. So veterinary research, there was only 3 papers I could find that weren't that, there's definitely scope for publishing. And publishing, I've published one case that's really interesting. Publish it so other people learn from it. Collaborate with human healthcare. I feel like there's a big lot of funding coming in when they really want to make a difference in the human outcomes from snake envenomation. Is there an opportunity to tap into that, with different collaborations or clinical trials? Like we got given over 100 vials of antivenom when I first did that clinical trial. And antivenom access and quality is another big thing. So yeah, I guess I think this is an exciting area for you guys. I think there's a lot of opportunity over here. Yeah, I'd love to open up to questions about how. I definitely, please take what I've said today with a great. This is all from our snakes, so some of it may not be relevant. So take any little nuggets away. Because how many, is snake bite something that's quite sick? Do you get runs where you'll see a heap of them, or is it not as common? You see a lot of snake bites or not as many? It depends, or geographically where you are, whether you're more rural versus the cities. Yeah. So same for us, but in Brisbane, we get a catchment of South Brisbane, and even in the middle of our city, we've got snakes roaming through. We've got snakes everywhere. So we see a hell of a lot of it. Our ICU just last weekend was pretty much full of snakes. The most I've treated in one day was 7 in a row. So they just keep coming. And they can, they turn up there like got you on the edge of your seat. You just don't quite know what they're going to do. And I guess my other thing to say is every envenomation case can be slightly different. You've got to look at that patient in front of you, and I still take stuff away and learn and imprint in my mind my pattern recognition of what that presentation and how it was slightly different. And I find them, they're really interesting when you actually get into the venom composition and what they're doing. All right, guys. Well, yeah, I guess it's been awesome. I really enjoyed it being here. We've now got another week. Oh, we've got some questions. Yep.
Yes. So we use 2-PAM in case of organophosphate poisoning.
You use what?
In organophosphate poisoning,
yep,
we use 2-PAM.
Oh, 2 pound, yep.
Yes. So
Yep.
can we use this 2-PAM in case of neurotoxic snake bite?
Yeah, no, it doesn't work, no. So for the presynaptic binding, once it's bound, it's time. If the venom is binding postsynaptically, the antivenom will reverse it. So no, antivenom would be your mainstay. Yep.
And in
Sorry.
neostigmine and atropine.
Yeah, again, antivenom. So we in our tick paralysis patients, we were messing around with a little bit of trying different options, but no, the way the venom works is I'd be using antivenom. I did see in some of the human literature over here when I was skimming through for your guys' snake that was mentioned, but it's not, it's not routinely. It was mentioned as an option, but there's no evidence to support that it's actually effective. So.
And so we have an in-house dialysis machine. Yep. So can we go ahead with the dialysis in case of neurotoxic or hemotoxic snake bite?
Yeah, so again, good question. It would be more for supporting your kidney function to help them while that kidney's having an AKI. To dialyze out the venom, you're much better off just giving antivenom. But again, I don't know whether the venom would be dialyzable and whether you could get it out. I feel like it's going to be antivenom would be your mainstay.
Thank you.
Yep. Oh, yeah, hang on, I can't quite hear you.
Yeah. So you had mentioned how they are paralyzed for multiple days at a stretch. Yeah. So any kind of nutritional management or something that you take care of during this time?
Yeah, no, good question. So our Eastern Browns, the peak of their paralysis is probably the first 3 days, and then they start to be able to army crawl a bit. They're normally on their legs by day 5. If they're a young, healthy dog, we sometimes don't. They're on on fluids, and generally 5 days they can get out of trouble. Sometimes they'll be regurgitating, and we don't want them to aspirate. And sometimes it's just, but as soon as they're kind of able to army crawl themselves and maintain sternal, we do let them eat if they've got to swallow. And so that may be kind of day 3, but if you're able to jump straight into a feeding tube, if we've got a big fat cat that's been envenomated and we don't want to have hepatic lipidosis in acute starvation, our snake cats who go on ventilators, we will sometimes slip a feeding tube in. In our snakes, in our dogs, I feel like we've just probably got more of a risk of aspiration than not, and they're normally only another day or so off eating anyway. So within that, and again, nutrition is so important, but it's kind of a window where if they're going to be getting better before that time, they can probably cope. Yeah.
The fluids means it's like dextrose containing fluids, or you're talking about parenteral nutrition, like the whole deal?
We don't do TPN unless some of our tick paralysis patients are on prolonged mechanical ventilation, and even then we normally try to feed them enterally before if their guts won't tolerate trickle feeding, we will go to TPN. But no, it's normally they're just on a balanced crystalloid, so Hartmann's maybe with some low level of potassium. We don't routinely put them on glucose unless they're can't maintain their glucose, so they're a little puppy. So the young puppies who can't maintain glucose will go on a 2.5 or a 5% glucose drip into Hartmann's. But mostly they seem to, we just keep them normally hydrated with maintenance fluids. We're not overhydrating them. Then they get eating. Yeah, they're really quite like. Poor guy. I feel very sorry for them because they're paralysed and they know they're paralysed and they can't do anything. We do use anxiolytics in them, so sometimes they're on microdose medetomidine CRIs because they're normally like a bouncy Staffy or a Jack Russell or some kind of Hooney breed that's very, you can see that they're a bit stressed and paralysed, and we do like to keep them calm. So butorphanol CRI or dexmedetomidine or medetomidine, low CRI if we've got paralysed patients, because I feel like otherwise you feel like you're just a bit cruel. Nursing care is really important with our paralysed patients. Our nurses are really constantly, we're keeping them in sternal recumbency. Their elbows, if they're a bit older, get quite stiff and sore. So we're doing recumbency change and passive range of motion, bladder care, really looking after them, soft bedding, because again, our ticks and snakes do stay paralysed for days. And eye care, if you've got a paralysed patient, we get eye ulcers really easily, especially if they've gone in an oxygen cage. It's very drying and fast oxygen levels. So we'll keep lubricating their eyes every 4 hours. So that's almost a standard of care that we don't even have to chart for it. The nurses just know that that happens, is we're getting eye care into any paralysed patient. But yeah, well, thank you very much. I think thank you for having me.